In order to start this topic, what we need to put in mind is the goal for the treatment of CML in the current stage is to control the disease, which translates into having the best possible duration of life and the potential for a functional cure, which is discontinuation of the treatment itself. And also you need to have a sustained quality of life, which translates into avoiding unnecessary complications. In order to achieve these two goals in treatment, we also have to put in our mind that adherence to treatment is also a necessary component to have a better treatment effect. Studies so far have shown that being adherent, meaning that you take your drug as you have been prescribed as strictly to that as possible, is necessary to have a better response to treatment. However, quality of life, especially side effect management, is also an important factor in sticking to the treatment protocol that you have been prescribed. Now, another reason that side effect management has been an important topic in the treatment of CML is in the last 10 to 15 years, the treatment of CML has dramatically improved, especially with the tyrosine kinase inhibitors. And although not all 5 drugs are available in our district, there are a couple of options that you can have within the tyrosine kinase inhibitors compared to what we used to have was only stem cell transplant and interferon, which had a much more side effect. So now that we are mostly using tyrosine kinase inhibitors, in this talk I would stick to the side effect management of tyrosine kinase inhibitors, especially the first 3 drugs, imatinib, nilotinib, and dasatinib, since bosutinib and ponatinib are not available in most of the Asian countries at this moment. Now, a little bit of a background about tyrosine kinase inhibitors and its effect. We have learned yesterday that all TKIs inhibit the BCR-ABL protein and its function. They all bind to the same domain of the BCR-ABL protein, although their structure is a little bit different. Now, if they all bind to the same protein and inhibit the same protein's function, you might wonder why there are differences in the side effect profile from different tyrosine kinase inhibitors. And that is because each drug not only binds specifically to BCR-ABL protein, but they also inhibit the function of other protein kinases, and that leads to the difference in the side effect profile. Now, I apologize. I'm not going to go deep into the different types of protein kinase inhibitors, the protein kinases that each drug inhibits, but from this slide you can see that each drug binds to different protein kinases, and thus some side effects are common among TKIs, whereas different tyrosine kinase inhibitors would have different side effects according to which protein they bind to and inhibit. Now, I know this is a busy slide, but just to illustrate that different drugs have different side effect profiles, for instance, superficial edema is more often seen with imatinib compared to nilotinib or dasatinib, whereas for some of the enzyme abnormalities, the blood test abnormalities you would see are more specific to nilotinib rather than imatinib. So there are different profiles according to which TKIs you are using and different side effects that you might experience. Another aspect of talking about side effects would be how to look at them. And one way to look at them would be to look at the different severity of the side effect. And you can see major side effects, which are more severe type of side effects, compared to minor side effects, which are less in severity. We have learned from yesterday from Dr. Ross's talk that imatinib does not have many of the major side effects, whereas nilotinib or dasatinib, the second generation tyrosine kinase inhibitors, are associated with, although few in, you won't see them very frequently, but you may see some of the major side effects and also the late complications that may arise as you take them in the longer term. Another way of classifying the side effects would be which organ system it affects. Typically, we would talk about hematologic or non-hematologic side effects. And also another way to look at the side effect would be, as I have mentioned before, whether it is specific to a certain type of TKI or it can be seen across different types of TKIs. So I'm going to move on to looking at each specific side effects that are more frequently seen with different types of TKIs, and I would like to start with the hematologic side effects. Now, for the hematologic side effects, this is usually transient and manageable, but it is seen with all types of tyrosine kinase inhibitors. The reason that we see this side effect could be due to the direct toxicity of the drug, but also because there are a lot of CML cells at the time of initial diagnosis, it suppresses the effect, the normal effect of the normal hematopoietic stem cells, and by initiation of the tyrosine kinase inhibitors, you would decrease the number of abnormal cells, but it takes time for the normal cells to recover, and that is why you may see these hematologic side effects. You typically would not realize what kind of side effect you have with this, the hematologic side effect, except for having a blood test. But on the blood test, you may see anemia, neutropenia, thrombocytopenia, with neutropenia and thrombocytopenia being the more frequently seen side effects. Because they are transient and manageable, the way to manage this toxicity is usually with transient discontinuation of treatments until the counts recover. However, if this persists for a longer time, you may have to decrease the dose of the tyrosine kinase inhibitor you are having. Because of the mechanism that I explained earlier, with the tyrosine kinase inhibitor reducing the number of abnormal cells, usually these hematologic side effects are more commonly seen in the first month of treatment. So in the first month of treatment initiation, you should visit your doctor more frequently, have your blood tests, and make sure that your counts are in the normal range. Now, moving on to the non-hematologic side effects, there are side effects that are common to various tyrosine kinase inhibitors, and there are side effects that are more specific to each drug. So it goes one by one through these side effects and how to manage them. Fatigue occurs commonly with tyrosine kinase inhibitor therapy, and it has the greatest effect on patients' health-related quality of life. Nilotinib, dasatinib, or bosutinib, the second-generation tyrosine kinase inhibitors, have a less frequency of fatigue compared to imatinib. However, usually fatigue is something that you can manage, and unfortunately, there is no specific way to manage the fatigue, except for managing your regular lifestyle or taking enough rest and not work too much. Now, for skin rash, it is observed in about 30% of patients treated with either imatinib or nilotinib. It is less frequently seen with dasatinib. They're usually self-limiting and manageable. If the skin rash is very extensive, you could either use antihistamines or steroids, or you can consider discontinuing the drug for a limited amount of time. Now, unfortunately, as also with other types of side effects, we would like to think if you have had a side effect in terms of cancer treatment, like other chemotherapy, whether having a severe side effect might be related to a better outcome of treatment. Now, there are a couple of drugs like the EGF receptor inhibitors, which is not used in treatment of CML, but other types of cancer, where having a skin rash and the severity of the skin rash is associated with treatment efficacy. Fortunately, with tyrosine kinase inhibitors, we haven't seen this phenomenon, and therefore, if you have a skin rash, if you notice something on your skin, please go to your doctor, because there are ways to manage this symptom and before it spreads all over your body. Another cardiac toxicity has been mentioned since the time of imatinib, and all TKIs have a potential of serious cardiovascular side effects. I'd go a little bit more in specific about the toxicities that are more specific to either nilotinib or dasatinib, as we have heard yesterday a little bit. But in general, tyrosine kinase inhibitors do have a suspect of having a cardiac toxicity, especially for patients who have an underlying cardiac condition or cardiac conditions predisposing to the cardiac incidences, like you have a diabetes or long-term hypertension, you are at a higher risk of developing toxicity. Therefore, and also this side effect is more likely to occur as late side effects, meaning that as the longer you take the drugs, the more susceptible you would become to having a cardiac toxicity. So a regular monitoring would be necessary to make sure that you haven't developed any cardiac toxicity. Usually the frequency is not very high, but if you suspect something, it's with the heart, make sure that your doctor knows that it is a potential of developing with TKI treatment. And then another common side effect is an altered glucose metabolism. You might have a high or a low blood sugar. You also wouldn't notice this unless you have a blood test, but especially if you have a diabetes that you have been on treatment, this is one thing that you might have to put into mind. Now, imatinib and dasatinib has an effect of lowering the blood sugar, whereas for nilotinib, hyperglycemia, meaning high blood sugar, has been observed. So if you have a predisposing condition, especially if you're a diabetic, please make sure that your blood sugar is not increasing. In terms of symptoms, gastrointestinal symptoms like diarrhea, nausea, abdominal pain, and vomiting is more frequent, especially with imatinib. And also, although I don't think bosutinib is used in any of the countries in Asia, it is also seen very frequently with bosutinib. Both nausea and diarrhea can be managed with medication. Also, especially in terms of nausea and imatinib, if you take imatinib after food and water, that is one way to get around with these symptoms. Unfortunately for nilotinib, because you have to take them on an empty stomach, if nausea is much of a cause of a trouble for you, you might want to consider changing drugs if that is an option for your disease. From here, I'm going to move on to a more specific side effect with each drug. Fluid retention, like peripheral, eyelid, periorbital edema, are mostly mild, but is frequently seen with imatinib. If you stop taking the drug, this symptom will go away, but other ways to manage this symptom would be taking either diuretics or restriction of salt intake. Musculoskeletal pain, bone pain, muscle cramping is also a frequent symptom seen with imatinib. Supplements with calcium or magnesium or those kind of supplements are also suggested to work especially for muscle cramps. Some physicians would suggest taking tonic water if that's available in your region. So there are ways to get around with muscle cramping as well. Now for nilotinib, symptomatic side effects are not so common, but it is more common to have an abdominal laboratory test, especially with AST, ALT, or bilirubin, which are hepatic enzymes. This is might also be more common in this specific population because it is associated with the polymorphism of an enzyme that digests the nilotinib. The UGT1A1 gene polymorphism is more frequent in the South Asian population than in the Western population, so you might experience this laboratory abnormality. It is usually manageable with interruption or reduction of dosage, and also even if your AST or ALT goes up, as long as it stays in a certain range, it doesn't actually affect you symptomatically. However, we do have to monitor carefully, and also if you have any baseline hepatic disorders like hepatitis or any other hepatic disorders, you might want to monitor more carefully for these types of abnormalities. Also, as discussed yesterday, elevated lipase or pancreatitis is more frequently seen with nilotinib. Although a few cases of symptomatic pancreatitis like abdominal pain and some pancreatitis that needs to be hospitalized is not very frequent. However, this is one thing that it may lead to discontinuation of nilotinib treatment. Also, Taking nilotinib may cause peripheral arterial occlusive disease, meaning that your artery might be blocked by blood clots. Although it is not very clear if this is associated, nilotinib is the direct cause of this PAOD, we should, as physicians, we do monitor closely, especially if you have pre-existing risk factors for artery occlusion, like neuropathy, hypertension, hypercholesterolemia. And this is especially a concern for the Western population because of the age of diagnosis and for the predisposition, because they have more risk factors compared to the Asian population. Moving on to dasatinib, pleural effusion is observed predominantly with dasatinib, and it is associated with dose, and they tend to develop with time. So the longer you are on treatment, you would more likely to develop pleural effusion. It is usually managed with transient treatment discontinuation, or you can use diuretic steroids. Sometimes you have to pull this fluid out directly with a needle from through thoracentesis. Now, patients who have pleural effusion have been reported to have dasatinib-induced lymphocytosis more frequently, which may be associated with increased response and prolonged survival. However, this is not clearly shown, and if you have pleural effusion, you need to have the symptoms managed. So symptoms that you may develop that you can find for yourself would be shortness of breath, or if you get tired more often, then that might be a sign of having a pleural effusion. Also, pulmonary arterial hypertension, as Dr. Ross explained yesterday, is also reported in patients taking dasatinib. Shortness of breath is also, as well as pleural effusion, you may experience shortness of breath as a symptom for pulmonary arterial hypertension, and early discontinuation of dasatinib is a way to manage this side effect. And sometimes you have to permanently discontinue the drug, and change of drug is necessary to manage this side effect. Now I'm going to touch a little bit about ponatinib, although this is not currently readily available in our countries, because it is coming in the market and also it is accessible through expanded access. Ponatinib and thrombosis is a major concern at the moment for us. Ponatinib is potentially very effective for T315I mutation, which is resistant to other types of tyrosine kinase inhibitors. However, last year, the FDA transiently discontinued the use of ponatinib because of the increased risk of both arterial and venous thrombosis. If you find, so if you have any pain in your extremities, or if you have a heart attack, that's an indication that you should not use ponatinib. So I know I've gone through all the side effects very quickly, but the key take-home message for me today is that for you to understand that most side effects of tyrosine kinase inhibitor therapy is manageable with either treatment or change of drugs, if that is appropriate for your condition. Because different drugs have different side effect profiles, and also the way that the side effect appears is different among each individual. Also, the way that the reason that we want to manage the side effect is because it is important for you to stay on your treatment without side effects and to have a long life with manageable quality of life. And if you have any problems with side effects, I strongly urge that you discuss with your physician which drug is optimal for you and whether changing a drug is an option in your situation. So I'd like to thank the organizers again, and also my colleagues at Keio University School of Medicine, and also last year I've spent a year at the Harvard School of Public Health, and I'd like to thank my colleagues and faculties there for helping me with my research. And I'll be happy to take any questions you have. Thank you.
Thank you, Dr. Eri. That will be quite a comprehensive subject. Okay, I would allow maybe a couple of questions from the floor before we proceed to the next. Yeah, Dr. Maruna.
I would like to know whether there are any significant drug interactions with tyrosine kinase inhibitors that we know. because that's a question patients ask most of the time, whether they should stop the drug when taking a certain other drug, or whether they should monitor something. So
And thank you for the question. And I know there are, with nilotinib, I think anti-hypercholesterolemia drugs there is a drug interaction, and I'm trying to remember the others. But there are some drug-drug interactions with certain drugs, but there aren't very many. And most of the times, you can manage with either changing of the other drugs that you're using, because like for hypertension or hypercholesterolemia, there are other substitute drugs that you can use compared to the different choices of TKIs. So I would suggest changing those drugs rather than changing the TKI just for the drug-drug interaction.
One more questions? Yeah.
Most of the side effects are related with imatinib. Then why is it being used most in comparison to other drugs?
So as Dr. Ross mentioned yesterday, usually imatinib, because we have a more long-term experience with imatinib, we know that they usually don't cause much of a severe side effect, although there are these minor, well, I know I shouldn't say these are minor because it's not uncomfortable, it's definitely uncomfortable for you with the side effect, but because these side effects don't cause severe or life-threatening side effects, and because the physicians have more experience with imatinib in managing those side effects, it is sometimes easier to use imatinib rather than the second-generation TKIs. For the second-generation TKIs, these side effects that are most frequently seen with imatinib is seen fewer, but there are these more severe side effects that can occur, especially in the late term, that can be life-threatening. So we do have to take those into balance to choose which tyrosine kinase inhibitor works best for you.
Yeah, one more, maybe the last one. Yeah.
I want to ask you about the ponatinib. As you said earlier, that it has activity against the T315I mutation. As myself, I have the T315I mutation. So will the drug be able to control the mutation, like to prevent me from getting resistant with it later?
So among the TKIs that are currently available, ponatinib is the only drug that has activity against T315I mutation. That doesn't guarantee that it works for every patient that has the mutation. So we also, if you have that mutation, we already consider whether stem cell transplant is going to be an option for you. Currently, ponatinib is back on the market in the States, and I know that the company also provides expanded access program to certain countries that ponatinib is not currently approved on the market. So that might be an option for you to use, and that might be, it's a little bit of region specific. For instance, in Japan, we don't have an access to the expanded access program that ARIAD provides. So that might be one thing that you might want to discuss with your physician.
Okay, maybe the last question, because I have the privilege to ask the question for the last one. Okay, because I'm the chairman. Okay, the situation in this region, the Asian community, is that we have not much option to change from one TKI to another. And how do you balance between intolerance or side effects whether we need to change to the next one? Because we have gotten not much option on second TKI.
So I think that's an excellent question. And personally, I think imatinib is still a very good drug because most of the side effects are manageable with, for instance, edema you can manage with diuretics. I did have trouble managing the muscle cramps because we don't have anything specific that works for the pain. And I did change some of my patients because they just couldn't tolerate the muscle cramps to a second generation TKI. But considering that second generation TKI wasn't available until a couple of years ago, I think still imatinib is a good drug as long as it's working for you in terms of disease control. And I think living in balance with side effects is something we can do with imatinib.